So here, grabbing hold of each of the pelvic girdle. This is not one that you want to be forceful with, but palpating for any tenderness, and then asymmetry here and kind of rocking it a little bit back and forth there. If there's pain there, it could be a sign of a fracture. But all right. And then you would also inspect the area, but because we're classmates, we don't need to take our pants off. All right. Now moving on to the legs here. Can you bend your knee for me and then kick out? So flexion, this one too, and extension of the knee. And then here, I'm checking for any ballottement, which is when I push down, it would feel kind of bulgy and spongy, and then looking for a bulge sign for any swelling of the knee, and also looking if there's any obvious deformities, any pain with palpation. And then we'll do the drawer tests. Anterior drawer, posterior drawer, and the Lockman, you only need to do one. And then checking the varus stress and valgus stress. And then McMurphy's. McMurray's. McMurphy's is not a thing. Okay. And then over here as well. Those are the anterior, posterior drawer, the Lockman, varus and valgus stresses, and then McMurray's. All right, then the range of motion of the ankles. Can you point your toes up to the ceiling, down to the wall, and then crinkle your toes for me? Can you curl your, yeah. And then inspection and palpation. Any tenderness, pain? All right. I think that's it. Did I miss anything on the list that we should demonstrate?
Leg length.
Leg length.
And varus and valgus.
It is. So, quick way, just lie back down for me. Check leg length. You just put their feet together and check if the malleoli are in the same place. And they look like they are, so. Hernias, yes. Have you lay back down. This is, you're checking here for an umbilical hernia. So before you start doing the auscultation, can you lift your head up for me? I would see bulging here. And then also with that same test, you can see if there's any separation of the rectus abdominis. I think that.
Lateral sternal border.
That's for the neural.
Oh,
The which one?
Lateral line.
The left and right sternal border.
Oh, yes. That's part of the cardiology. So usually when you listen to the heart, you want to listen to them lying down. But you also, to hear certain murmurs though, it's easier to hear that with the patient sitting up and forward. And so I'll have you lean a little bit forward and then deep breath in and then all the way out. And then you would do it again, left and right, sternal border.
The diaphragm.
The what?
That's why cause it says with the diaphragm, but I thought that's what you were listening for a murmur, wouldn't it be with
I think some murmurs are with the diaphragm, some are with the valve.
You can usually hear.
It says with diaphragm.
Yeah, I switched it to the diaphragm.
No, okay, I just wasn't sure.
Okay, yeah. Yeah. So, as far as murmurs and hearing them and listening, most stethoscopes only have the diaphragm.
Right.
So, you should be able to hear it with the diaphragm. It's higher pitched things are easier heard with the bell. So bruits, you want to check with the bell, for sure. Murmurs,
I think it's just S3 that's with the bell, isn't it? If you remember saying that.
I have a note that says that
Yeah.
on my paper.
okay, yeah, so.
Because that's the one
It's
with
like, but like
higher
valvular murmurs usually
S3 is
aren't
when you hear
described
the
as
line.
high or low pitched. It's more intensity.
Deep palpation of the liver tip and splenic enlargement.
Okay. So, can you lie down for me again? Yes, that's good sport. So, take a deep breath in for me. So, I'm palpating the liver border here, and you want to feel that it's smooth and not spongy. You can breathe normal. And then, over here for the spleen, deep breath in for me. And I should not be able to palpate the spleen. Okay, thank you. Breathe normal. So that one, deep breath in, pushes the liver down, and you can feel it right underneath the rib cage. You might have to push up into it. The spleen is kind of make a handle, grab, love handle area, and you should not feel it, but if you do, that's not good. Anything else?
You breathe in for all those tests. You breathe in for the liver tip, the spleen, and the
because
choline.
they sit underneath the diaphragm, and so when they take deep breath ins, it moves them down and below the rib cage, because your rib cage protects a lot of your organs, and so as they take a deep breath in, it just moves things into a easier range to palpate. Same thing with when you're palpating the gallbladder. Take a deep breath in, moves the gallbladder down, and if I push where the gallbladder should be, kind of up to the right and underneath the rib cage is where you want to be pushing. And then if they, then either you push really hard or they have a positive sign. Any other questions? I did not do the straight leg raise. That's part of the musculoskeletal when you're doing the spine. Can you raise this leg for me in the air? And then that one. It's not passive. I do it. It's passive. I do it. Any pain in your lower back?
No.
No. Any pain in your lower back? That's one you need to do as the provider.
Is passive like checking range of motion, the one you did when he was standing?
So passive movement is when I do it.
Oh.
Active is when he does it. So in this one, you just need to do the active range of motion.
So for the valgus and Verum, like stress tests, what are you just like pushing in and
Yeah,
out?
so what I do is I hold the knee, and to check the valgus, I push on the outside of the knee while pushing on the inside of the ankle.
Okay.
So it, instead of just trying to do it all right here, it's easier because this is a longer lever. And then for the varus stress, I push, like kind of hold this stable and push the ankle in.
Okay.
I think you just need to do it at 0. Does it tell you a degree to do it? Okay. 0, 30 degrees are good places to do it.
Yeah, I think it's supposed to be 30, I think.
When, yeah, there, like we, in my clinic, we tested it and recorded it at 3 different angles, so. Any other questions?
That aortic, like when you're trying to see the diameter, you do it that you're.
You kind of, cause, yeah, I mean, eventually it should be,
like
cause you
half
wanna
past.
make sure you're like, okay, it's only 2 fingers. Well, if you didn't check out here, you might be missing
You have to go
it.
really deep.
It is very deep. This is something that on thin patients, it's easier to do, but if your patient is normal to, like, I mean, this is like very skinny people that you can usually palpate it on. So you can say you're doing it and just, you know, push around, push really deep, but usually on most of your patients, you're not probably going to feel it. So,
I have a question.
yes.
Actually, so Pete has a question.
Oh, well. Hi. So when you're testing, you should bring a pen and a tape measure so that you can actually mark the liver. The spleen, I don't think you need to measure the spleen.
Because it would only be diagnostic if we could actually
Yeah.
take it out.
I mean, you can get the dullness, the splenic dullness. You can percuss that, but you don't need to measure it.
Okay, and then one last question
Yes.
for the lower extremities for the valgum. They were having us do some wild and crazy figure eights with the lower extremities. Is that
So that is the McMurray test.
okay?
So the technique behind it, well, the theory behind it is that you're checking the 2 menisci. So if I'm checking the lateral meniscus, I want to put a valgus stress on the knee, and then I check the foot first with external and then internal rotation of the foot, and then when I'm checking the medial meniscus, I'm putting that varus stress on the knee, and then doing the external rotation and the internal rotation of the foot. The figure 8 thing is if when you're very skilled at those movements, you can do it quickly.
Okay.
So
that should be the expectation for the CSE to be able to do it in that type of rhythm.
I mean, no, it's not expected. As long as you're saying what, like, because there's 2 different techniques to do it. You can do it like the slower. I do it this way, then that way, and then switch my stress on the knee and repeat the movement. You can do it that way.
Thank you.
So, but yeah, either way is acceptable.
Can you, maybe you said it before, can you explain when you're doing the hips, you're
Mhm.
inspecting and palpating, what is rotation and shortening?
I think that's
To
it,
check
yeah,
like if they're
fracture.
the same.
Is that what they're asking?
Or I think it's
Inspect the leg length
It's the
notes.
same thing.
Yeah, I think
Um,
it's like leg length, but like if you.
Inspects and palpates the hips. So the hip is not your pelvis. The hip is the joint, and so you would be checking for internal, so the rotation of the leg, and then shortening. Yeah. So with different fractures and dislocations of the femoral head within the hip joint, the leg can be displaced and it can present in an internal or an external rotation. So it's just an inspection. So I would inspect the hip joint, and if the femur is internally rotated versus externally rotated, and then also if there is a dislocation, the leg is actually higher up because it's not in the joint, and so I would see that deformity, and so it would be a shortening because one leg would not be the same length as the other because it's out of alignment up here.
And then when you inspect that, would you have the patient standing or not?
If their hip was dislocated, I don't think they'd be able to stand. So, and this is another thing too, because you're not doing the opposite. You're observing over clothing with your classmates. You might not see, but you can definitely something you'd be able to palpate. And then the shortening I could quickly look at by looking at where his feet are. The rotation might be a little bit harder over clothing. Any other questions? All right.
Thank you.